Hello, I'm Lisa, a pediatric physiotherapist for babies and toddlers. I've seen firsthand how small, everyday habits in modern parenting can lead to big issues for our babies. In this podcast, I'm going to show you how to prevent those issues, treat them if necessary, and restore the joy to parenting. Hello, and welcome back to the Best for Baby podcast. I'm your host, Lisa Rogers-Sargent, and today I am joined by the very impressive and very inspiring Gina Mundy. Gina is a childbirth attorney and has spent more than 2 decades analysing cases where things didn't go according to plan. She has looked through thousands of medical records and spoken to medical personnel and really studied the cases where things didn't go right. And as a result, Gina has a really unique perspective and loads of experience in this field. Recently, Gina has used her skills and her knowledge in this field to help parents to minimize their risks when going into childbirth. And to do this, Gina has written a book, A Parent's Guide to a Safer Childbirth. There it is. And she's also the host of the Childbirth Attorney podcast. So it gives me so much pleasure, and I'm really, really grateful to have you here, Gina. Welcome to the show today.
Thank you, Lisa, for having me, and thank you for the wonderful introduction. I'm excited for our conversation today.
Thanks. Gina, to start, can you tell our audience a little bit about yourself and your past career and how that's all kind of come together to put you where you are now, where you're really basically an advocate for parents who don't know any better before they go into childbirth?
Sure. Thank you, Lisa. So I have been a childbirth attorney for approximately 23 and a half years. And just so your audience understands what that is, when something goes wrong during labor and delivery with mom or baby, and it results typically in one of 3 outcomes, which is not great. And the family brings a lawsuit against the hospital. That's called basically a birth injury case, birth injury litigation. And that's what I've been involved in now for over 23 and a half years. And I'll tell you, from my very first case until my most current case, they're the same issues over and over and over again. So about 19 years deep into my career, I started to, tell people I'm older now. So I was getting to the point where my daughters were getting older. They were going to have babies. I actually just had my first grandbaby 3 months ago. Yes,
Oh,
I'm a grandma.
wow. God,
Yes.
congratulations.
Thank you. And if you read the introduction to the book, you would read my niece. She had a baby and she ended up having more of a traumatic birth. And that's when I knew I had to get this information out to try to prevent it. Now, she was very lucky, and mom and baby are absolutely fine. And as you would read in the introduction, but it kind of got my wheels turning that I have this information. So basically, bottom line, instead of getting involved only after something goes wrong, I'm trying to get involved before childbirth to prevent what I see in these cases and help parents have a safer childbirth, help parents have a healthy baby. Because I'll tell you, the hardest part of my job, by far, anybody in this field will agree with me, is the day we sit down with the parents and we have to hear about, the day their child was born. Because like I had just said, one of 3 outcomes is, something just not great. Obviously, with baby, whether it's permanent damage, sometimes babies pass, and then unfortunately, even in the cases, sometimes mom passes. But there's definitely decisions and information that parents know going into childbirth that can help, prevent anything like that happening to them.
Yeah, I think it's incredible that you say in the whole course of your career, it's always the same things you're seeing. And I know as healthcare professionals, we have to be careful what we say because there are set protocols and this is what they do. And so we know that's going to happen to our patients, when we're speaking to people. And so we don't want to make them afraid of it. So we're always careful and we don't want to get into trouble because there can be, all kinds of recourse for us. So we're always very limited. And so there's not a lot of talking about these things, about these patterns that you've identified. Um, and so I find, I'm not in the hospital at the time of birth, but the work I do is obviously when things have gone wrong, and I can see through my career, oh, that's interesting. There's some patterns, but I don't know. Is it based on this? Is it true? What are the statistics? So, yeah, it's amazing that you're doing that and that you have a voice to share this with people, because I think it's really, really valuable information. And with
Thank
that,
you.
can we start? Can we dive in? Can you tell us some of the most common patterns that you are seeing that kind of end up triggering a more difficult and traumatic birth?
Well, based upon our pre-show, I don't think you're going to like my answer. And for anybody listening, it is chapter 11 of my book is dedicated just to the common facts, the common decisions that are important to help you, prevent anything bad from happening. But let's just get right into it. The number one most common fact in a legal baby case is the drug Pitocin. And as we talked about pre-show, everybody likes inductions.
Yeah.
So when there is an induction of labor, so Pitocin, I'm sure your moms know,
Can I just
but just in
explain
case,
here from this side? Because in the UK, we don't call it Pitocin. So, Pitocin is obviously synthetic oxytocin that is used to induce labor and for a few other reasons. In this country, we call it Syntocinon, which is just, or sometimes we also still say oxytocin, but it's just that it's the synthetic version. So, all my mums listening, we're talking about Syntocinon or oxytocin. In the States, they call it Pitocin.
yes, I'm glad you clarified that. And I'm going to go ahead and call it oxytocin because what you said the
Okay,
first time, I'm not going to get that. I'd have to practice.
that's probably better.
Anyway, um, unfortunately, oxytocin is in every case. And those are the labors where things tend to go wrong to the point where mom or baby become permanently injured. So it's extremely important that if you are having an induction of labor, that that you understand Pitocin, how to have a safe delivery. And I'll tell you, chapter 14 of my book, I do have all of my tips for having a safer induction of labor. But number one, and actually you may know this, in where you are in London, how high do they usually turn up the Pitocin, or there's usually a doctor's order for Pitocin? How do you know what that
I
max
don't
is that the
know.
doctor?
I don't
Okay.
know.
All right. So here in the United States, the typical max dose for your first order. So actually, let me back up for your audience. If you're going in the hospital for an induction of labor, the doctor, and it should be the same way in London, has to order the oxytocin.
Yeah.
And then the nurse at your bedside will administer the oxytocin. And in the States and in London, most likely, I hope, but conceptually, or oxytocin is very easy to understand. You start at 1 and in the United States, and you go to about 20, and that's where the nurse has to stop and then contact the doctor if they want to go above 20. And in the States, they will go up either by 2, so they'll start the Pitocin and they'll increase it by 2, 4, 6, 8, 10, or some doctors in the United States just increase it by 1, 2, 3, 4, 5. And the doctors who increase it by 1 typically increase it a lot slower than the doctors who increase it by 2. Here's the deal with Pitocin. Pitocin is a very individualized drug, and how, Lisa, you may respond to it may be completely different than how I respond to it. And if you've never had an induction of labor, you don't know how your body is going to respond to Pitocin. So my biggest piece of advice if you're having an induction is go slow and steady and just let it hit your sweet spot, because the manufacturers, the people who make the Pitocin, wrote in their pamphlet, and you can literally just go on the internet or oxytocin. I gotta remember to call it oxytocin. I apologize. They say you only need to go to 6 in order to mimic spontaneous contractions.
Okay.
You don't even need to go above 6. And they said there's very, very few times where you even need to go above 10. Now, in the United States, they like to go 1 to 20.
Okay.
So what happens is contractions, and this is another thing everybody has to remember, contractions are not only hard on mom, contractions are hard on baby.
Yeah.
So what happens is oxytocin is making the uterus contract. So baby's in the uterus. And then the oxytocin is making, the uterus contract down on baby. Now, nobody freak out. Babies are made to handle contractions,
Yeah.
and this is a natural part of labor. The problem is, and what happens in these cases with oxytocin is that they increase it too fast, too much, and there's too many contractions, and baby can't handle it. So while babies are made to handle natural contractions, they're not made so much to handle too many contractions
Yeah.
from the drug oxytocin. And then that's where babies start to get into trouble and whatnot. So I always recommend take it slow, go up by 1, give it time. And let me tell you the story with my granddaughter. My daughter actually had a Pitocin or oxytocin induction.
Oh,
And they started at 2. Well, they started at 2. The nurse came in right after to increase it to 4. And I stopped the nurse and I'm like, wait a minute. Why are we increasing it? We just increased it to 2. Why are we increasing it to 4? And why can't we just increase it to 3 when we do decide to increase it? And the nurse looked at me like she saw a ghost. Now, here it's a local hospital, so they knew I wrote a book. They knew who
okay.
I was. Um, and they still looked at me like, what? This is my job. Don't tell me what to do.
Yeah.
So that nurse left because I'm like, don't touch the Pitocin or
Mm.
don't touch the oxytocin. The nurse, after she looked at me like I was a ghost, said, okay, I'm going to go get another nurse. She left. Another nurse comes in and she's like, do we have a problem with the Pitocin? I'm like, well, we just increased it to 2. Can we wait a little bit longer? And when we do increase it, we'd like to just go to 3. And
Yeah.
you know what? She didn't seem very happy either. But guess what? That's exactly what happened. That nurse left. She came back in a while later, gave my daughter some more time to kind of acclimate to the drug.
Yeah.
She is slowly increased it to 3. We waited a little bit longer, probably longer than they wanted to wait. Then we got to 4. And guess what? She delivered her baby at 4. She never even got to 6. So it's sometimes with the nurses, they know what they're doing. They have their protocols. The doctor puts in, go up by 2. Now they have to go against the doctor's order if you only want to go up by 1. But I'll tell you, my daughter's friend delivered at that same hospital the following week with the same practice. And their Herpetocin sky high,
Oh,
emergency C-section, traumatic childbirth. Now, mom and baby are okay, but this was not the birth story that she wanted.
yeah.
So again, Pitocin, oxytocin, that is when, and then that typically the contractions are very strong. So then, there's more interventions.
Yeah.
There's the epidural. The epidurals are in most cases.
Yeah.
And then what goes hand in hand with induction epidural that doctors love to do, break the bag of water. And that is another absolutely huge decision that parents, I don't think understand because the doctors, even in my daughter's case, they're like, it's time to break your bag of water. What?
Okay.
No, that's our decision. And they make it sound like this is what we're doing, but it's actually a decision for mom. But breaking the bag of water goes hand in hand,
Yes.
with an induction with the doctors typically.
Yes.
So here's the deal with breaking the bag of water. When things go wrong during labor and delivery, it is almost always after mom's water breaks.
Hmm. And do you mean
Yep.
if it breaks spontaneously there, or do you mean when it has been broken?
Both,
Okay.
but it's more in the cases, more often than not, it's when it's been broken by the doctors.
Okay.
Because here's the deal, sometimes mom's water breaks, but she's not going into labor, so they may start the Pitocin, and then still something will go wrong. But think about it. Water is surrounding baby for 9 months. Everything's great. And they break the bag of water and then it drains out. And that whole environment in the uterus changes.
Yeah.
How does it change? Nobody knows because baby's inside a mom.
Yeah.
So that actually leads me to my next point. But did you have any comments, any questions
Yeah.
on the
So much.
oxytocin induction? I know, but
Wow.
I'm going to the next. I'm going to the next. You better stop me.
Stop. I'm trying to remember everything. I wanted to say, like, with this, obviously, I think we, particularly here, most people are here in the public healthcare system when they have their babies. It's quite commonplace. And so nurses are under pressure. They're overworked, obviously. We don't see the same midwife with each antenatal appointment. And so they have very little time. So they might briefly say when you go into labor, or if you go over 40 weeks, or if you have gestational diabetes, or if you're a geriatric mom like I was, we have strict rules, and then we'll induce you, and this is what you can expect, and that's it. You don't get much information. But just listening to you here, you suddenly realize it's not just an induction that you're going to get. You get induction, then it means you're probably going to get a whole lot more interventions.
Yeah.
And I don't think we make that connection. And again, listening to you, I think what happens is the whole trajectory of the birth is going to change. It's interesting, your story about it going gently, because I think going up slowly, like you say, there probably mimics the natural birthing process. Whereas if you're suddenly going really quickly, it changes everything. It puts the baby in a state that they're not ready to be in. And I think we know, obviously, the oxytocin is causing the contractions. It's causing all that squeezing. And like you said, that's important in labor. I mean, we know that's clearing the baby's lungs out of all the fluid, and it's getting the baby ready. It's helping the baby through. It strengthens the baby. It's there. Babies can handle that. But I think, like you said, I didn't know this about the levels of the oxytocin. And obviously, if you are more than doubling what is mimicking natural childbirth, it must translate into a huge amount of pressure onto a little baby. And potentially with very little time, those uterine muscles have also got to relax in between, and everyone can get a breather. Mum can gather her strength, baby can gather its strength. And I think with those high levels, I suspect we're not getting a lot of relaxed downtime. We're getting sustained contractions, much stronger contractions. And then you say, which I've never thought about before, the water breaks, either because they're breaking it purposefully or spontaneously. And you don't have this lovely cushion around the baby to protect them from all the squishing and squeezing. And now suddenly that pressure is directly on the baby without the lovely water cushion around them. So I think, you say, the nurse looked at you like she had seen a ghost. I think, yeah, and I'm not British, I'm South African, but I'm very much British having lived here. So in our culture here, we're very, we do what we're told, and we're non-confrontational. And I think to start saying, oh, I'm not comfortable with that. How do you have advice on how we can just advocate for ourselves to say, let's slow things down. I'm not comfortable going up, or what is the best way to do that?
You're just going to have to stick your heels in the ground
Yeah.
and literally stand your ground. And that's what I did. And here's the deal. I think I had a good relationship with the nurses. I was calm. I
Yeah.
was stern. I was still friendly. And I think more importantly, I was respectful.
Okay.
So if you stay calm, even if they look at you like you're a ghost, trust me, they wanted to evoke an emotional response from me, and I stayed as calm as could be, and I just stared. And don't be afraid of silence. Say your piece, don't over explain it, and stop. And silence makes people very uncomfortable. They will, and they, this is a little bit of communication technique, probably from being a lawyer and in depositions and litigation and whatnot. But I said my piece and that was it. And I was nice, I was respectful, but this is the way it was going to be. And, I think the first nurse was trying to scare me by getting another nurse. And then when another nurse came in, is there a problem? And I'm like, problem? We're just trying to have a safer childbirth. I'm literally a birth injury attorney, and I wrote the book on how to have a safe Pitocin induction. What? So, but I stayed calm.
Yeah.
And you know what? I said my piece. I was silent. So that's the best recommendation that I can give. And you have to remember, all caregivers are different.
Yeah.
So your nurse, your midwife, their personality, who they may be, maybe you do have somebody you may have to explain more. Maybe they're new, maybe they don't understand, or maybe you have somebody who's been doing it 25 years, then it's their way or the highway. You may have to take a different approach. But most nurses, midwives, you should be able to just hold your ground
Yeah.
and they listen to you. And you know what? If worst comes to worst, tell them to go to ginamundy.com. Be like, safe for childbirth. I read the book. I know how to have a safe Pitocin induction. Because here's the deal with the chapter in my book about a safe oxytocin induction is it's based upon everything that I've seen go wrong since February 2003. So, all of these Pitocin inductions gone wrong. It's like, why?
Yeah.
And so, okay, this went wrong. Okay, again. Okay, so nobody do this. Have this is how you have a safe one. But again, the gist of how to have a safe one. And you know what? You, Lisa, did such a great job. I'm gonna steal some of your words. When you said going slow mimics the natural progression of labor. Yes, that's brilliant.
Yeah.
So, and you're right, it does change Pitocin, especially if you go up fast, the whole direction of your labor. So, yeah, but
I
I
think
love
there's,
those points that you made.
I think there's so much hope in the way you say that as well, because I think in my head, just from what I've seen, I kind of fear the induction. I fear the oxytocin. Um, but actually, you can use it to have your birth experience that you wanted. You can use it to stay on track. Um, and it sounds like, I mean, why is this still happening if there's so much evidence of it being better to go slow? Why is it still being administered so quickly? Why are we still having all these issues? I think it's so important, I guess, for parents to be prepared and to imagine. That's Nobody wants to imagine having to be induced, but imagine if you are induced, do your research so that when you do have to confront a nurse, you can take Gina's tips, um, but also you know what it needs to be, you know where it needs to go up, um, because once you're prepared,
Mhm.
it's so much easier to stay calm and say your piece and then be silent. I like that a lot.
Right. And that actually is a good segue into my third point. How, especially if you have an epidural, how do you know if your Pitocin is adequate? Y- How do you know if your baby is handling the Pitocin induction? You look at the fetal monitor. Now, in London, are you guys able to see the fetal monitor during birth?
We do
They
in
usually
some
have one
places.
right next to everybody's bed.
Um, I I think in most hospitals they do.
So in London, then you need to unequivocally request to see the baby's heart rate during labor. Here's the deal with the baby's heart rate. I've had so many doctors testify that the only way a baby can talk to them during labor is through their heart rate.
Okay.
Hence, if a parent, an expecting parent, a mom, a dad, can read their baby's heart rate, it's like their baby can talk to them during labor.
Mm,
Their baby can, and I'll tell you, as a birth injury attorney, the first thing I learned how to do was read a baby's heart rate.
okay.
And it's not rocket science. I know the medical community wants to keep it to themselves and call it medical. It took me an hour to learn how to read the baby's heart rate. And it's a beautiful thing because I can look at a strip. and I did this with my granddaughter. I can look at the strip and I can tell you if baby is a rock star or if baby's struggling.
Okay.
So why wouldn't expecting parents want to know this? And a lot of decisions or recommendations by doctors, nurses, midwives are actually based upon the fetal monitor
Mm,
because again, baby is inside mom. This is what makes labor and delivery so hard with baby and sometimes bad things can happen because baby is not visible. So
mm,
the best moment to moment information we have on a baby is literally their heart rate.
yeah.
So I suggest to all parents, and I wrote it, of course, I wrote a chapter on it, but one of the biggest things that I recommend is understand your baby's heart rate. And at a minimum, if you just understand the terminology. So let's say they're not going to let you sit and stare at it. They're not going to let your husband sit and stare at it, your mom sit and stare at the fetal monitor because they're just going to keep it to themselves. Sure. I do not recommend that, but if they want to do that, no matter what, if something happens and baby's not tolerating the induction, they're going to use words that you have to understand. They're going to
Mm,
say, well, the baby's heart rate is dropping. There's, decelerations
mm,
or the baseline, what the baseline should be. They may say the words variability, which are the squiggly lines. And the terminology for a fetal monitor tracing is very common sense. So it's really it'll take an hour to learn, but if something does happen and they come to you and they're trying to describe the tracing and why maybe they're recommending a C-section, why they're telling you, hey, you got to go on your side again, why they're trying to give you an IV or oxygen, they may describe the tracing, and then if you know the terminology, you're going to be able to understand what they're
mm. Yeah,
saying more, and be more involved, in your care.
yeah.
So, and I can tell you when the baby's heart rate starts to decline in response to the drug oxytocin, it gets chaotic in those delivery rooms.
Yeah,
So everything gets a little more chaotic. So you do want to have that knowledge base before you
mm.
go in on
That's
the
such a
fetal
good
monitor
point.
tracing.
I never even thought of that. I mean, I had, as I told you, an elective cesarean section, but I never even thought about wondering about her heart rate in it. And I suppose in a elective, it's all very quick and you don't expect there to be any changes to her heart rate. But I never thought of that. And I think it is such a simple thing. And just for our listeners, I think, Gina, you're talking about the strips as like the reading that you see on all the medical television series of the heart doing this, basically. The ECG, we call it ECG, I think you'd call it EKG reading. And that's the rhythm of the heart. But even more simply, something that I think a parent can just understand quickly is the heart rate. And knowing that a baby, a newborn baby or a baby who's not yet born is going to have a really high heart rate. I mean, normal for them could be 160, 140. Um, and if it goes up a little bit, that's okay. We expect that. It's exertion, but it's when the heart rate starts to drop and gets lower, which I think in adults we're always aiming for a lower heart rate, but a little baby, it's when it starts to drop that we worry. Um, and actually understand, at 60, if a baby's heart rate gets to 60 for an adult, that's quite a good heart rate. But at 60 for a baby, obviously they're going to consider that not effective. The heart's not pumping quickly enough to effectively get oxygen to the brain. Mostly that's what they're worried about, but to the whole body. So that's the equivalent of the heart not working anymore, is a heart rate of 60. So I think for parents to just know that, I think is really important and not something I would have ever thought, and never thought to have a look at my baby's heart rate during it. So that's a great piece of advice. With
Thank
that,
you. I
is
appreciate
that
that. I find it crazy that the medical community tries to keep it from parents. And even if they have somebody in the room like a doula, they like to classify it as medical interpretation. So you have to be a doctor or a nurse to be able to read fetal monitor strips, which to me is completely crazy.
mm. And legally, I mean, I know you can only speak about in the States. Legally, can you, as a non-medical person, as a family member or doula, insist on having access to that information and reading it?
Oh, 100%.
You
Yeah.
can.
So in the baby's heart rate is so incredibly important to managing someone's labor. that it's next to every patient's bed, the heart rate graphs.
Okay.
Every nurse's station, all the heart rates are graphing. There's the doctor's lounge, the heart rates are graphing. Here, they can remotely log on and watch the heart rate graph because
Okay.
that's how important the baby's heart rate is. And I'll tell you, in the cases, what is almost always at issue, the baby's heart rate. And it's when the baby's heart rate, like you were just describing, goes down, which for baby is not good, they don't react fast enough. And then it goes
Mm,
on too long. And then that's when baby can, get into trouble
mm,
because with the low heart rate, their heart's not pumping enough oxygen
mm,
and blood, to the brain and whatnot.
yeah. Gosh. So, so I think in your book, so you look at you kind of being prepared and understanding medications for induction when it happens, watching the baby's heart rate. Do you kind of ever see things where things have gone wrong when someone hasn't been induced um, and, going through labor, and where you would say you should be monitoring baby's heart rate as well during labor which hasn't been induced?
This is the best question ever, Lisa.
Oh,
So I would stare at these cases and be like, what can we learn? Especially when I was writing my book, just breaking it all down. I want to have everything in this book. And what I didn't realize is what's not in a birth injury case. So what you're saying with basically, if it's not induction, it's natural, spontaneous vaginal birth, skip the drug, skip the Pitocin. So those cases, all natural deliveries with no Pitocin, are very few and far between. In
okay.
my career, I have only had a handful of cases not involving the drug Pitocin. So if that is actually a tip for how to avoid, a potential birth injury, is
Gosh.
if you can, if possible, if medically okay, skip the drugs, skip the Pitocin, skip the unnecessary interventions. And as much as you can, go for, again, 5 words, all natural, spontaneous vaginal birth. Those are very, very few and far between. It's almost like labor is just allowed to progress how labor is meant to progress, which is obviously, to get baby here safely.
Mm. And I'm going to ask you all the questions now. In labor, that so there's no induction, but mum gets to a point she's in too much pain. She asks for an epidural without any oxytocin. Have you seen much there in many cases like that?
No,
Oh, really?
no.
So it's literally the drug.
No, it is actually the drug oxytocin.
Okay.
So I struggled with that in my book. Because listen, here in the States, almost everybody gets an epidural.
Yeah.
So every case does involve an epidural,
Yeah.
but it's also because Pitocin contractions are way worse than normal contractions.
Okay.
So that is usually why everybody then
The epidural.
gets the epidural.
Okay.
So in the spontaneous, the births that I've had, sometimes mom does have an epidural, sometimes she doesn't.
Okay.
I think as long as you are staying away from the Pitocin, that's
Okay.
definitely the number one problem, even though epidurals are in almost every childbirth case.
Okay.
Does that make sense?
Yeah. Yeah.
Okay.
And a personal question. Have you had cases where there's been traumatic, like brain injuries or anything like that during a cesarean section? Not an emergency cesarean, because I can assume yes, because obviously the emergency, trouble would have started before that. But in elective cesarean sections.
Lisa, you are so great with your questions and giving your audience the information they need to know if they, help them have a safer childbirth. So here's the deal. I have never had a case involving an elective C-section. And birth injury attorneys typically have elective C-sections.
Okay.
So yeah, a lot of moms who just want to avoid everything will just go for the elective C-section. So yeah, there are no cases that I know of
Okay.
to date
Yeah.
after 23 and a half years
Yeah. And so that
involving any
was
kind.
my understanding. Obviously, we don't speak
Mhm.
about it so much here. And for the listeners, we're certainly not advocating that everyone should have a cesarean section. Again, my experience was that I'd worked with children where childbirth had gone wrong, so my perception was skewed. I didn't get to see happy stories of childbirth. I didn't see all the children who had been unaffected. I was working with children who had been affected. I was also someone who suffered from anxiety at that stage. And also, every time I had an antenatal appointment, they would say to me, "You're a geriatric mother. You're over 40. You're a geriatric mother." And that wasn't helpful, you know. So I was majorly, you know, super, super anxious, and I knew I couldn't relax in the birthing process. And we know that is essential. You're never going to have a calm, easy labor if your body is full of adrenaline and cortisol. So that was a good decision for me. But we know of all the benefits, obviously, of a natural childbirth. So just to reiterate, that's not what we're promoting, but that was a very personal question for me, just to feel a bit better about my choice, because I think I do get judged for saying I chose to do that rather than allow my child all the benefits of natural birth.
So that is how you just explained it, Lisa. You sound, as we talked on pre-show, literally that's how I explain it with myself. I cannot relax. I'm not the doctor or the nurse who gets to see the good and the bad. I only see the bad. And my daughter, she asks, what do I do? Do I have an elective C-section? She knows my stance on it. Just not even my stance, but you know, that most birth injury attorneys have elective C-sections. She's like, should I just have an elective C-section? And we went over the pros and the cons of everything, natural birth, Pitocin or oxytocin induction, the induction of labor, and elective C-section. And guess what she chose?
Natural.
Yep,
Yeah.
oxytocin induction.
Yeah.
So the number one most common fact in baby cases. So I never tried to, and she asked my advice and I refused to give it to her. I said, again, pros and cons. So yes, we're not out advocating for elective C-sections. It's just something for you guys to understand in your brain,
Mm.
because maybe there is something making you nervous about labor and delivery for whatever reason. And you're like, wait a minute, I can't relax either.
Mm.
Maybe that might be a good option for me. So but no, my daughter, she went, as you know, oxytocin induction, which gave me a heart attack. But I'm like, don't worry, I know how to make it safe.
Yeah.
And it was a great birth. It was a beautiful birth experience with the
Oh,
induction and labor.
which is amazing. And I think I'm going to tell everyone now about your daughter and you the story, because I think it's the flip side to what I've been saying, you know, for my case, but it's actually how lovely, you know, that is that amazing story of being well prepared, having someone to advocate, knowing what you know, and applying that, and then having the beautiful birth journey that she would have wanted. I think that's
Yeah.
amazing. Um, so are there any other sort of things other points that you would have shared with us, or those the major ones?
I got two more points.
Oh, brilliant.
One of my biggest tips to expecting parents, learn before labor. This is why. During stressful moments, your brain is not designed to absorb new information. It's designed to make decisions based upon what you already know. So you cannot wait until childbirth to learn about childbirth. And in the birth injury cases, I've heard the same heartbreaking words over and over and over from the families. I wish I would have known that before labor.
Mhm.
And so just getting out there, looking at everything, even if it's not my book, just learning about labor, learning about the lingo, learning about childbirth. So if you do have to make a quick decision, if you do have something happens, you have that knowledge base to go off of. Without that knowledge base, you're going to be making decisions that you don't know.
Yeah.
So, or the doctor may be telling you something, like, okay, because I have no idea. And that might not be a great decision.
Yeah.
So what I recommend is that everybody do a birth plan.
Yeah.
So go through your interventions. Do I want an induction? Do I want an epidural? Do I want someone to break my water? What if the baby's heart rate goes down? Do I want a C-section? What about vacuum, forceps? Just learn about it. You don't even have to bring your birth plan. You don't need to bring it to the hospital because it's just the act of being in your own home, preparing a plan and just learning about childbirth. And then wait a minute, you're stuck on something. Okay, well, I'm going to go ask my doctor. So if I'm having an induction, am I going to go up by 2? Am I going to go up by 1, 3?
Mm.
What's the max that they like to go to?
Mm.
So it's just, again, preparing that birth plan is just your way of looking at everything and just preparing, having that knowledge base. So once you enter into labor, which you do enter a different state of mind, you're just ready. You have the information that you can rely on.
Yeah.
So that's the big one. Learn before labor. And there was one other one. Did you have anything I love your insight on stuff, Lisa. You speak and I'm like, I write down what you say so I can repeat your words. So
Uh, I was just going to say, like, it's so awesome when you talk about this, about being prepared and learning, because I'm so scared to share information because you don't want to fearmonger. And I couldn't have a natural birth because I was afraid. I had so much fear. And I think there's so much blessing in ignorance and people going into childbirth and not knowing. So they go in with a positive, calm attitude and they have a lovely labor and it's wonderful. And that was always my standpoint. So, lay back on what I say, and I'm careful on my podcast not to share too much. But I think the way you share is, like you say, you actually have to learn, because yes, most people will go in happily unaware of this side of things that we're talking about and have a lovely labor, but it might not work that way. And if you aren't prepared, then it's that much worse. And I think your whole book looks at minimizing these things, reducing the chance of it happening to you. And so why wouldn't you want to reduce the chance? Why wouldn't you want to be aware? And I think there's probably a difference between working in it like we do and understanding and learning and then moving on and going, in case that happens, this is my plan, and now I move on from it.
yes, it allows you to pivot, better, easier. So you had mentioned at the beginning, I have a podcast.
Yes.
My very first episode was a mom whose labor did not go as planned, and the baby ended up with pretty severe brain damage. And it's just a heartbreaking story. Obviously, it was an induction of labor with oxytocin and whatnot. But this mom was literally a nurse. Now, she was not a labor and delivery nurse, but she was in the medical field and it still happened to her.
Yeah.
So, and when we had the podcast, she's like, well, I didn't know anything about labor and delivery, but she just thought, I'm medical, I am a nurse. This isn't going to happen to me. And she learned a lot after
Yeah,
after
it's a
she had
whole
her
different
baby.
field.
Yeah, she really
Yeah.
did. And it was heartbreaking. She read my book after
Yes.
and she said the heartbreaking words, I wish I would have known that before
Yeah.
labor.
Yeah.
So it was now she didn't say that in the episode because when we did the episode, she had not read my book yet. She read my book after we podcasted. And actually, she's supposed to come back on the podcast, but she has a case against the hospital. So until that's done,
Mm.
she's not going to she'll come on the show after. So,
Yeah. Yeah. Gosh.
and then one other piece of information or one tip, I guess, that I have. Lisa, do you guys have doulas that you use in
Yes.
London?
Yeah.
Okay. I am a huge fan of
Okay.
doulas, and I recommend everybody have a doula.
Okay.
And what I find remarkable is that in 23 and a half years, I have never had a doula involved in a case. I'm convinced it's because doulas help parents bring babies safely into this world. And when I looked up the research, there's a 2017 research landmark review, actually, out of Cochrane,
Yeah.
and it looked at 15,000 deliveries and basically concluded that labor support persons like doulas give mom and baby a better birth experience, meaning less C-sections, less operative vaginal deliveries, less epidurals, more vaginal births. It correlates exactly with, the what in the cases, what happens in the cases and what not. It was fascinating study. But the research supports, my opinion that if you can have a doula present, and it's just those second set of eyes dedicated to mom, staying in the room, it's just such a big difference. My daughter, now I was in the room, my daughter still had a doula.
Okay.
Yeah. Oh no, I'm a huge fan of doulas.
Mm.
And I've asked my other birth injury attorney friends, they're like, no, they'll be like, Gina, what's a doula? And
Oh,
I'm like,
really?
exactly. Nobody knows.
Nobody knows.
Well, in
Yeah.
our world, that's good. Remember, keeping in mind too, everyone has elective C-sections. But anyway, um,
Yeah.
they're like, no, we don't have doulas in
Yeah.
cases. And I'm telling you, and like we talked about with the birth plan, mom does enter a different state of mind. And this is what doctors have testified in these cases, that the standard of care or what a doctor should do is give mom all of their options before labor even starts, because they do go into this, different state of mind. And think about it. I mean, if you've ever been pregnant, I remember being 9 months pregnant and in my living room, calm, looking down at my belly, going, how is the baby going to come out? Even my third pregnancy, I'm like, you got it. It's, and of course, elective C-section. So, you go in and, but luckily,
Yeah.
whatever. But when
Yeah.
you actually go into labor, so I told you I did have a C-section, but I did go into labor with my first child. And, I woke up and it was interesting. And I'm glad this happened to me. I woke up or 2, 3 in the morning, I must have been exhausted to sleep until that point, but my contractions were so strong. The way to the hospital, I was breathing through them. But but you're having contractions. It's the only time in life where being in pain is okay.
Yeah.
But I was in that car. I'm like, just get the baby out. Just get the baby out. I just wanted the contractions to stop. But you do, I was in 100% different state of mind. So, but having that doula there. And then another thing with the doulas is labor and delivery units. So in birth injury cases, labor and delivery units are usually slammed. And a lot of times it's on the weekend and it's in the middle of the night. So those are more skeleton
Yeah.
crews. There's not as many people. But when the labor and delivery units are busy, it's just the nurse, everybody's running around like crazy. They can't get the specific attention. They don't have the medical person in the room, even though doulas are technically not
Mm.
medical.
Mm.
But their life is attending childbirths. So they know what's going on. Can they give medical advice? No. But do they know childbirth? Yes, like the back of their hand.
Okay.
So it's nice having somebody like that in the room to go get a nurse, say something's wrong, get an intervention or whatnot. But yeah, in the cases,
Yeah.
nobody has a doula. And many,
Yes.
many times, yeah, the
Gosh.
units are extremely busy.
Yeah. I wanted to ask you about doulas because I didn't know about them certainly before I had a child, and I've only recently come to know about them. I've interviewed one on my podcast as well. And I just remember her saying, we talk everything through, and she's had this lovely, calm sort of voice. And she said, and my whole thing is that in all the pre-birth sessions, I make the person calm and make them associate me with calmness. So as soon as
Mhm.
I walk in, they're stressing and whatever, and then they see me and they go back to that place of calm. Or I'll say something, I
Yep.
constantly touch them a certain way, and then I do that again at that stage. And it brings them, so it calms them down as well as just know, apart from all their knowledge, it's just like a psychological calming tool. Um, and just been so
Yes.
amazed by that.
You know what? I love that. And I've been listening to a lot of like YouTube stuff on voices, and I've actually learned that somebody's voice, when they're calm, can actually then calm other people, lower their heart rates. Like somebody's voice can either increase or decrease somebody's heart rate. So if you have a good doula, I mean, there's nothing that beats a good doula. You have a good doula who can come in and just calm. And two, what about, if you have a nurse and you're like, don't turn up my pit, and the nurse is like, you got this good doula going, why
Yeah,
don't you let us, doulas would be like, why don't you let us talk?
yeah,
And then that little interruption, and then the nurse goes and gets busy. And, the
yeah.
doulas have their little tricks and their little
Yes.
tactics that are
And I
actually are
suppose,
very,
yeah,
yeah,
they
very
also
impressive.
like used to being an advocate for someone giving
Hmm.
birth, and our partners, and certainly, I mean, a woman in labor is not going to be able to advocate for herself. You cannot expect her to. But her
Right.
partner, that's not their life's job either. So suddenly, you throw them in the spotlight with all the pressure on them to say, don't increase my partner's oxytocin, whatever. That's too much for someone who that's not their field to do either. So a doula, who that's their job, will probably be much better. And you, as the birthing mother, will feel more
Hmm.
reassured knowing you've got someone like that who can do the talking for you and who can advocate and who understands all of this. So yeah, I just wanted to ask you just sort of final kind of questions. With your experience, have there been any treatments, modalities, or things that you've seen implemented once labor has gone awry, things are going wrong, and they realize baby's in trouble, and soon after, in that period, that you have seen put to good effect or have good outcomes for these little ones and mum?
So when baby gets into trouble, so let's say there's an induction, there's too many contractions, there's not enough rest time for baby gets in trouble, and they just know it's time to deliver baby. A lot of times what happens in the cases is they move to, and it's called operative vaginal delivery. So that's where they use a vacuum or they use forceps, and they just try to get baby out vaginally as fast as they can. And unfortunately, in some of these cases, a vacuum is used and a vacuum will pop off,
Yeah,
and then they have to convert to a C-section. But when you use a vacuum, you have to wait for mom's contraction. So you have to wait for a contraction, pull on the vacuum, wait for contraction, pull, and then after 3 times, they're supposed to abandon and hit C-section. So unfortunately, what I have found in my cases is going to a vacuum, and that delay, it's too much time. And then that's when baby ends up with, permanent injury to the brain, as opposed to skip the vacuum or do forceps. Now, here in the States, forceps is like the old way of doing it.
yes, yes.
However, what my older doctors love forceps.
Mm,
And what they say is that with forceps don't pop off.
yeah,
So vacuums pop off. So basically, you're going to deliver a baby if you use forceps. Vacuum, that's dicey. And so when you
okay.
spend that extra 6 or 7, 8 minutes, that's the time where if you would have just gone to C-section, baby would be okay, but they attempted the vacuum. So what I always say is that something, especially if you're going to have induction of labor, is to talk about do you guys use forceps, vacuum to expedite a vaginal delivery, make it go faster, baby gets in trouble, or do you just go to C-section? What do and then you guys talk about it. And then
Yeah.
that way you're ready. And I have had a lot of moms just, if baby's in trouble, they don't want operative vaginal delivery. They just want a C-section.
Mm, mm. Gosh, I think, yeah, anecdotally through patients I've seen, I've had a few mums who've said to me they started with the Ventouse, the vacuum, and then that didn't work, so then they went to forceps. Is that
Oh,
is that not something you do there? They go vacuum, if it
no.
doesn't work, straight to C-section.
Yes. In
Yeah.
the States, you're straight to C-section.
You see,
So
yeah, they'll
vacuum doesn't work, then that's a C-section.
Okay. So I think here in the UK, they'll still go from the one to the next. And I
Hmm.
think because probably, as you say, the forceps tends to be successful. So they can then go to forceps and bring the baby out. I think there is quite a strong culture of avoiding emergency C-section if possible here. So I think that's maybe why the added step. But that's
Now, I
really
will say
interesting.
one thing about forceps. Forceps could mess up the vagina,
Okay.
the vaginal area. So the thing with vacuum, and a lot of the reason the doctors will use it is it doesn't have any impact on the vagina. Forceps could injure your vagina. Not they can be very, very bad down there. So just keep that in mind. Now, listen, you're at a point, if they're trying to use it, your baby needs to come out. You may not have a choice, but again, that's where it comes into play of, getting ready
Yeah.
and knowing your decisions, talking to your doctor ahead of time. And all of that should really come out when you're doing your birth plan,
Yeah.
vacuum, forceps. And I have a whole birth plan chapter in
Okay.
my book.
Yeah. Gosh, I did not know that about forceps because I always wondered, because they said, there was less, you can get minor injury to a baby's head with forceps that you don't get with the vacuum. So I thought that was the extent of it. And, you've never seen a baby with long lasting forceps damage. So I wondered, but I didn't realize it's vaginal damage to the mother as well. Gosh,
Yes.
so
Yeah, 100%. It's, yeah, very scary. So, and that's why I think a lot of doctors just try the vacuum.
yeah. Um, and I'm not sure how to fit this in, but it was such a great point on one of your episodes, that I wanted to just highlight it because I loved it so much. One of your guests spoke about, if you don't want something to happen, because here it is quite a strong culture of we are strongly advised what we should do,
Mhm.
and we're not always sure how to say no because they're telling us this is best for the baby or whatever. And one of your guests said you can say stop halfway through, and if someone says stop, you are basically withdrawing consent or you are making it clear you're not giving consent for whatever's coming next.
Yeah.
And then she also said if you can say, I don't feel safe anymore, is this safe? I don't feel safe, because then they have to do something. If someone's not feeling safe, they have to prove that you are safe or take action to make you feel safe. And I thought that was really great as well.
Oh, she was great. I think wasn't that Clara?
I can't remember because I listened to
She was
so many.
brilliant.
Yeah, all of them. Yeah.
Yeah, yes. Because I get asked those questions. I mean, you kind of asked me, well, what do you do when the nurse looks at you like you're a
Okay.
ghost? And I'm like, well, it's just this is what you got to do. But her is great too.
Yeah.
Stop. I don't feel safe. Those are two great pieces of
Yeah.
advice. And keeping in mind that all decisions are left up to mom. If the doctor, and even with my daughter, we're doing this, we're doing that, and I'm like, that's our decision. But okay, let's
Yeah.
talk about it, daughter. Okay, this is your decision. That's what you want. Okay, you know what? A lot of the time, I mean, obviously not all of the time, we were fine. Okay, that sounds good, doctor. That sounds good, nurse.
Yeah.
I also, handpicked her doctor, so because I know who's good out here and whatnot. So
Yeah. And that also, I wanted to ask you, um, when you were talking about the hospitals, in the late night shifts, the weekend, the timings, do you see good hospitals also having issues in those hours, or are there hospitals that happens more than others? And so we should do our research and avoid those hospitals, or is it something you need to be aware of if you go into labor on the weekend?
smaller hospitals, that's where it's a huge problem. So the bigger hospitals are like if they're teaching institutions
Okay.
or whatnot with the big NICUs, the advanced care for baby. Here we have different levels, level 3, level 4 hospitals. Their skeleton crew is not really a skeleton crew, not as much as a small community hospital. So if you're delivering at a small hospital, and I'll tell you, a lot of hospitals around here that are small have closed for this reason.
Oh,
Oh
wow.
yeah, because what happens is they're small. There's not too many patients.
Okay.
And So during the evening, the anesthesiologist, which you need in order to do a C-section, they're not on site. The pediatrician's not there. So when the baby's born, if something's wrong, there's no one, there's the labor and delivery nurse to care for the baby, but they're off site. And the deal is they have to be at the hospital within 30 minutes of being called. So in a Pitocin induction and baby starting to struggle, I mean, baby can crash like that.
Yeah.
And if you're at a bigger hospital, even their skeleton crew, they're going to have an OR that's probably open. They're going to have an anesthesiologist on site. A smaller hospital, they need to open the OR. They need to get the anesthesiologist out of bed into the hospital, ready to go, by the way, for an emergency C-section. And same thing sometimes with the attending OB/GYN who actually does the surgery, and then the person who would then care for baby at birth, they're not there either. They got to come in. So the yes, midnight weekends, smaller hospitals, it can get pretty scary, which is again why a lot of them here have been closing actually in the last couple of years.
Yeah. Sure. Wow. And just to finish off, I was going to ask you, and you basically answered it, but just like a final pearl of wisdom as such, I was going to say to you, if your child was going into labor imminently, what would your top piece of advice be? But now that we know you have and you are a recent grandmother, what is your top pearl of wisdom for all of us, or anybody who might have another baby or be expecting a baby?
Learn before labor.
Okay.
That's it. And it goes back again, how our brains are wired. Our brains are not wired to absorb new information during stressful moments. And in childbirth, it can be stressful during. Now, you know, at the end, you're going to have your beautiful little baby and everything's going to be great. But having that knowledge base that you can rely on to make your quick decisions, make good decisions, talk to your doula or whatnot, it is literally life-changing.
Yeah. Sure, I think so. And I think so many of the things we said, we talked about just if you know this before, if you prepare this, then you can implement it throughout. So, yeah, really good advice. Um, Gina, thank you so much for coming here with all your wisdom and your knowledge and sharing it with us. I think anybody planning to have another baby, don't do it before you've read Gina's book. I'll put the links in the show notes, and I'll also put a link to your podcast because I think there's so much for us to learn. There's a lot of talking points about things that we're a bit nervous to talk about here as healthcare professionals. So I'm really grateful that you've come up and opened our eyes a little bit to that world. So thank you so much. I really appreciate having you.
Thank you, Lisa. You're very welcome. And I just appreciate all the kind words and you also giving me the platform to come here and, help your audience have a safer childbirth, a healthy baby, or even people they know. So thank you too. And you are absolutely brilliant. I loved our conversation. I'm like, hold on, you got to come on my podcast now because my audience would absolutely love you. So
I'd
thank
love
you.
that. Thank you so much.